Ladies and gentlemen, friends and colleagues, all from all where you are, all the points where are you following for this meeting. May I take this particular opportunity to welcome all of you into this meeting. We are doing hand surgery for general surgeons, and we have been we have hosted a couple of seminars that includes 3 or 4 topics on hands, anatomy, approaches to hand examination, and we had a couple of videos to see, and you can recall that hand surgery is very critical.
We can hardly hear you, Mugisha.
Okay, here you can hear me.
Yeah, that's better.
Yes, all right. Well, let me restart. I welcome all of you into this meeting. Today is another day where we're meeting for Surgical Thursdays, that 90 minutes dedicated to surgery and surgical education. And this is continuous surgical education that's being brought to you by NetCare Foundation and in collaboration with Alliance for Global Clinical Training. We have been doing this for a year and a half, and we welcome all of you to today's meeting. The topic for today is about hand infection. Dr. Bill Schechter, who is an emeritus professor at the University of San Francisco, will be leading us from now. Dr. Bill, you are welcome.
Okay, thank you very much, and good evening to everybody, and thank you for making some time to be with us. Now, just Mugisha, can everybody see the slides? Can you guys see the slides?
Yes, okay. We do.
Okay, perfect. All right, so those of you who have been with us over the last couple of weeks from the beginning of this section on hand surgery for general surgeons had to suffer through a couple of hours of hand anatomy. But now, as we begin these more clinically related topics, you'll see why I thought it was important to spend a couple of hours on hand anatomy to bring everybody up to a certain level, because we're going to get into the details of clinical management of problems. And the first thing we're going to talk about is hand infections, and we probably won't need an hour and a half to get through this, and then we can start on some tendon injuries as well. But at any rate, hand infections rather are a big problem, and I suspect they're a big problem in your practice on the African continent, wherever you may be. It certainly was a big problem for me in my practice around the world, and particularly in San Francisco, where we have a big drug use problem and a lot of upper extremity infections related to injection drug use. And there is a spectrum of hand infections that ranges from cellulitis, which is, of course, just a soft tissue infection, to various types of abscesses, paronychia, felons, suppurative flexor tenosynovitis, deep space infections in the hand, all the way to necrotizing soft tissue infections, which can take the life of a person and even result in amputation of the upper extremity. So it's a big problem. And let's sort of get into the details now. Whatever type of infection you have, there are certain basic principles of treatment. And the first is elevating the hand and putting the hand in the position of safety or the position of function. And we had a wonderful video last week from Dr. Kirk Watson, who I presume he is no longer with us, because he was a very senior guy when I was a young person. But he gave us a wonderful lecture on the fact that the position of function is the wrist in 30 degrees of extension, the MCP joints flexed, and the thumb abducted. And the reason this is so important is remember, well, 2 things. One is if the hand gets stuck, frozen in a position, this is the position that we want it to be in, because this is the position of function. And if you all take your hand and take 2 fingers and squeeze your hand, and now flex your wrist and try to squeeze your 2 fingers, and you'll see that your grip strength is very weak. Now extend your wrist and do the same thing, and you see that you have a much stronger grip. So you want that hand to be dressed with the wrist extended, and then you want the MCP joints flexed and the thumb out. And I always would joke with my residents that if you got a can of beer, in order to initiate grasping the can of beer, you have to have the MCP joints flexed, right? And you get your fingers around and your thumb, which is now abducted out of the plane of the hand in opposition, around the can, and then you drink the can of beer, and then when you've finished, you flex your sublimus muscles. That flexes the PIP joints of the finger, and that bends the can. And then when you're finished, you use your profundi to really squeeze the can closed, and then you throw it away. So I would use that as a joke, but I think it's important to remember it because it really gives you the idea of grasping. You initiate grasp with the lumbricals, which flex the MCP joints. You get the thumb out of the plane of the hand around it, and then the sublimi grasp it, and then for a power grip, your profundi flex the DIP joints of the thumb. So that's the way we want to use it. And then you always want to have the hand elevated. If the patient's mobile, you want it to be in a sling. If they're very sick, we talked about last week, I think we showed the sugar tongue splints, where the patient could just lie in bed with long arm sugar tongue splints, with the elbow flexed, the hand up, and then the plaster fixed in such a way that you have the hand in the position of safety, as shown here. Or the alternative is to put a couple of pillows up and have, basically the hand has to be above the heart, because water runs downhill, right? And you want all that edema and swelling to run back to the heart via venous drainage. And one other point, that is obviously no restrictive tight dressings around the arm, which then could form like a tourniquet. So if the guy's got a tight jersey on or something like that, and then it flexes his elbow, that tight restricted clothing could act as a tourniquet and impair venous drainage. So that's the basic way we want to manage hand infections, or in fact any hand injury for that matter. And it's so important. And we talked last week a little bit about the importance of dressing and how you can do a beautiful operation, and if you make a tight dressing, you can totally ruin the entire operation just by failure to maintain venous drainage. Now, in terms of, and of course, tetanus prophylaxis is important, and you guys know more about tetanus prophylaxis in your particular situation than I do. But just the current recommendations, of course, is that for clean wounds, the patient should have a tetanus toxoid injection within 10 years, within contaminated wounds within 5 years, and then you can consider administering tetanus immunoglobulin, particularly. Probably, my guess is many of your patients have not been immunized against tetanus. I don't know what the public health situation is in the area where you're practicing, but my guess is that you're seeing a lot of tetanus cases. I certainly have in the areas where I was working with in Africa. So you have to pay attention to tetanus. Okay, so cellulitis, you guys know all about cellulitis, the swelling, erythema, ascending lymphangitis. You know, ascending lymphangitis in the old days before antibiotics, that had an extremely high mortality rate. If you had that red streak, hand like that and a red streak going up the arm towards the axilla, in the days before antibiotics, that patient had a good chance of dying. And the other point we made last week, you see a hand like this that's so swollen like this, even though it doesn't look like it, that patient is in the intrinsic minus hand, or in other words, opposite of the position of function. The swelling will pull back the MCP joints. And so you have to realize when you see a patient like this with cellulitis, that hand is in the wrong position. So you've got to, as you're treating the infection with antibiotics, elevating it and getting rid of the swelling, you want that wrist to be extended and the MCP joints flexed. Now also, not everything that looks like cellulitis is cellulitis. You have to consider the fact that you may have an underlying abscess or even a necrotizing soft tissue infection. And we're going to talk about that at the end of the talk. But you want to make sure that you don't have underlying pus. Now, if you've had an ultrasound machine, you can actually look for an abscess with the ultrasound machine. You can put a needle in it to see if you can find some pus. But the bottom line here, I think the bottom line here is at the end of this thing, when in doubt, if you're not sure whether there's an abscess or not, make an incision. You're never wrong to make an incision, put some retractors in there, look around and see if there's an abscess. And then because you can treat cellulitis to the cows come home, but if there's an underlying abscess, you're not going to solve the problem. Now, why is this not advancing? Let's see. Okay. Now, somebody, I think 2 weeks ago, asked about paronychia, and I said, well, hold on, because we're going to talk about paronychia. So here we are. So a paronychia is a common problem, as surgeons were often asked to deal with it, and it's basically a subcuticular abscess between the eponychium and the paronychium of the finger. And we're gonna talk. We haven't talked at length up until now about the anatomy of the fingertip, but we're gonna talk about that in a minute, so you can really see what a paronychia is and how you manage it. It's associated with nail biting, finger sucking, and occupations that require fingers to stay wet and dry. Now, the organisms are going to, of course, vary depending where you are and what your local flora and fauna are in terms of the bacteria. But where I work, the most common organisms are Staph aureus and hemolytic strep. The paronychia may be unilateral, and it's on one side of the finger. It may be bilateral, and sometimes there's a horseshoe abscess that goes right around the eponychium on both sides. So the initial treatment of paronychia are warm soaks, elevation, splinting, and antibiotics. Just what we talked about. And usually for a minor paronychia, you don't have to go through the whole shtick of getting the patient in the position of function. If it's a minor thing, you can just have them elevate the hand and soak it and frequently, and then start antibiotics. The antibiotic of choice, you're going to decide based on what antibiotics work for soft tissue infections where you are. Usually in the United States, in most places now, you have to use a penicillinase-resistant penicillin or a first-generation cephalosporin. So here is, as promised, here's a picture of the anatomy of the fingertip. So here's the distal phalanx right here, right? And as you know, you have the terminal extensor tendon inserting on the dorsum of the distal phalanx. You have the flexor digitorum profundus inserting on the volar aspect of the fingertip. And And you're not going to see these structures when you're managing, hopefully, when you're managing the paronychia. But here's the eponychium, which is that skin fold over the nail. And then you have the nail itself and the nail matrix, and then you have this basically this fatty tissue with lots of strands of fibrous tissue going through the fatty tissue, connecting to the distal phalanx. So, an acute paronychia, of course, is an abscess between this the eponychium and the nail bed. So many times, if it's early, you can manage it with hot soaks and antibiotics. On the other hand, if it's forming a real abscess, then you can elevate the eponychial fold, drain the abscess, and you can, we'll show you the different types of incisions momentarily that you can make. And if the abscess, however, is dissected underneath the nail plate, then you can take out the outer third of the nail. And there's all sorts of descriptions in books about removing half of the nail and all of this. But in my practice, if I had to remove the nail, personally, I just removed the whole thing and then packed it with gauze. So I don't have a slide about this, but there's first of all, you have to have good anesthesia, and we'll talk about the anesthesia for dealing with these things in a moment. But a good way to remove the nail is just to take a small mosquito clamp, usually straight. Make sure you have good anesthesia and test it before. Make sure your patient is numb before you do this, because if you don't, you're not going to make a friend. It's going to hurt like hell. You take that straight clamp and just go right underneath the nail, on top of the nail bed. Go straight all the way to the end of the nail. Spread the clamp. Then grab the nail from one side with the clamp, and just open it up like a book and pull it out, and you can get the thing off, in less than a minute. And then what I do is, now I've got the nail bed exposed. I take a little Vaseline gauze, cut it to size, and just put it on top of the nail bed. Put it on top of the nail bed, and then pack it in underneath the eponychium, and just let it sit there. So that is, management of a simple acute paronychia that requires drainage. In other words, you treated it conservatively. You're not making any money. It's getting worse. So you want to get it, and the thing is underneath the nail. You want to get the nail out, get the whole thing drained, and then just put a little Vaseline gauze there, or whatever type of dressing that you have. And this is an example of using an 11 blade, getting underneath the eponychium and draining it. Now, sometimes you have to make a more aggressive incision if the abscess is greater. So you might have to extend extend this drainage from the side of the nail around towards the proximal part of the nail, and even tee off, so to speak, here to get good drainage. And then sometimes you'll be dealing with a horseshoe abscess. That is an abscess that goes from one side of the nail to the other around the proximal part of the nail. And so in this type of situation, you're going to make bilateral incisions. That is, you're going to elevate a flap on the radial and ulnar aspects of the fingertip, and then even elevate a dorsal flap, and then take the nail out. Now let's see. Hopefully, we have a picture of that. Yeah, here we go. So you make you're going to make your incision like this. Come around here. You're going to elevate this side, and this side, and then pack the whole thing open with a nice. I like Vaseline gauze, but there's nothing magic about Vaseline gauze. You can use any kind of gauze, and then and then when you take it out, of course, you're not going to rip it out. That's going to hurt. You're going to soak it out. Now, a word about anesthesia. The best way to manage these, in my opinion, is to use a digital block. But you have to be careful with digital blocks. remember we went over the anatomy of the digital nerves in the previous lectures pretty carefully. And you can remember that they run on either side of the fibroosseous tunnel in zone 2. And you can access the digital nerves at the base of the finger or in the palm. And sometimes, since the palm skin is thick, sometimes you'll have an easier time, less discomfort for the patient if you go in through the dorsal skin, which is usually a lot more pliable and less thick, and access the digital nerves that way. Now, I don't have, I should have gotten a video off of YouTube to demonstrate the digital block. Now that I'm giving this talk again, probably I'll do that in the future. But at any rate, there are a couple of tips for digital blocks and cautions. Do not use a digital block if there is erythema and fusiform swelling that extends near the MCP joint. If you do, it is possible to basically introduce bacteria into the MCP joint. And remember that the MCP joint is white, right? There's cartilage, there's bone, there's collateral ligaments, which are all white. That means it has bad blood supply. So if you introduce bacteria into the MCP joint, you could end up with a pyarthrosis, and then you may have to amputate the finger. So if you're going to, the digital blocks are great for paronychia, except if the infection is extending into the proximal finger. If that's the case, my advice is don't do a digital block. The second thing is that, particularly if you're inexperienced, you give a digital block and it doesn't quite work, and then you give more and you give more and more. Well, remember that you've got two very small blood vessels, the digital arteries, which are end blood vessels. And if you fill that base of the finger up with a lot of local anesthetic, you could create a compartment syndrome there and end up with an ischemic finger and lose the finger. So usually, my advice is not to give more than a cc or a cc and a half of local anesthetic, because if you load that finger up with a lot of local anesthetic, you could create a compartment syndrome and end up with a dead finger. That's the second caution. And the third caution is that, and this is a general caution in general, and I always talk with my medical students about this: never inject a drug without inspecting what it is, and never ever inject a fluid that's sitting in a pan that the nurse puts you there. You got to always know exactly what you're injecting, because if you do a digital block with xylocaine with epinephrine, a lot of times you can get away with it. But remember, epinephrine is a vasoconstrictor. If you do enough digital blocks with xylocaine with epinephrine, you're going to end up with a dead finger and have an amputation, because those digital arteries are going to go into massive vasoconstriction. So make sure that when you inject the local anesthetic, that it does not have epinephrine in it. And of course, many of them do, because it prolongs it increases the duration of the local anesthetic. Okay. Any questions or about paronychia or cellulitis, or does anybody want to tell an experience, either good or bad, with any of these kind of infections before we go on? Mugisha?
Yeah, thank you very much. This is very common, and you have highlighted the management.
Okay, so these may be, somebody asked about paronychia a couple of weeks ago. That's why I spent some time on it. Now, another,
Continue. Yeah.
so if there's no other comments.
I just did
Yeah, go ahead.
an incision and drainage right now of the same thing.
Oh, you just finished doing it? Okay. All right. Well, that's great. And I encourage you guys, I'd like to make this as interactive as possible. So if you guys got your own experiences and you may even disagree with some of the things that I say, that's perfectly fine. We want to try to make this a conversation. All right. Well, if there are no other thoughts about that, let's go on to felons. Now, of course, felon in English has two meanings. One, the first meaning, the more common meaning, is somebody who's a criminal, who's been imprisoned, is a felon. But it also refers to an abscess on the volar, over the volar distal phalanx. And usually the mechanism is a penetrating injury to over the distal phalanx, or the pulp, or maybe sometimes a crush injury over the distal phalanx. And the thing about that's interesting about a felon, remember I told you that there are these fibrous bands connecting the skin to the distal phalanx that traverse through the fatty tissue over the distal phalanx. Well, sometimes and pus can get trapped in this area. So if you have a patient present like this, which is a felon over the distal phalanx, the treatment is same general treatment: antibiotics, position of function, and then antibiotics. But you usually, almost always, you have to drain these felons. You have to do incision and drainage. All right. So the question is, how do you do incision and drainage? And if you look in the textbooks, you'll see all sorts of incisions like that you can see here. And I'm going to tell you that there's only one incision that you need to use, and that's this. Make an incision where the abscess is pointing. Don't make it complicated by where you have to do a big dissection and cut through all sorts of fat and all sorts of fibrous septate. Just drain the thing where it points, get it in there. You take your clamp and spread a little bit, break up those septi if there are any feeding drainage of any particular of any isolated pus, which usually it does not, and then you just put a little dressing on it, have elevation, position of function, and then have the patient soak the finger a couple of times a day in warm water, warm soapy water, and antibiotics, and then you'll have a happy patient in a couple of days. So that's the management of the felon. Now we're getting to some more problematic infections. And this one is suppurative flexor tenosynovitis. Now remember, last week we talked about the fibroosseous tunnel, or maybe it was 2 weeks ago, the fibroosseous tunnel through which the flexor digitorum sublimis and profundus travels, and then and it glides through this fibroosseous tunnel to flex the BIP joint with the sublimis, remember, and the BIP joint with the profundus. Well, if you get a penetrating injury that enters this fibroosseous tunnel and introduces bacteria within there, you can get an abscess within this tight, confined space. And the way you diagnose this is the signs of Knabel. Now, who was Knabel? Knabel was a surgeon in Chicago, in the United States, in the first part of the 20th century, 1920s, 1930s, etc. And he wrote a textbook on hand infections. And regarding flexor tenosynovitis, he said there are several cardinal signs. What are the signs? First of all, you have diffuse fusiform swelling of the digit. The whole digit is swollen. Second, the finger is held in a semi-flexed position. Why? Because if you extend the finger, that puts a stretch on the profundus tendon, and that causes pain. So the patient is going to have his wrist flexed and his finger flexed, try to take tension off. Then the next thing is if you palpate gently along the flexor sheath, it's going to have pain. And then a lot of times, the pus will extend down into the palm. So you'll even have pain over the beginning of the flexor sheath in the palm, in distal palm. And then there's pain with passive extension. So how do you test for passive extension? Well, you don't grab the finger and move it like that, because even if the guy doesn't have flexor tendinosus, but he's got cellulitis, if you grab the thing and start moving it like that, it's going to hurt. What you do is you take the tip of your thumb or your index finger, whatever nail you want, put it on the nail of the patient and just flick it. And that's going to move the profundus tendon. If you flick it like that and it hurts, the patient has undoubtedly has flexor tendinosus. Now, I wrote a paper decades ago when ultrasound was just coming out, where we studied patients with flexor tendinosus, and we described a bullseye sign where you can ultrasound over the flexor sheath, and you can see that the flexor tendons in the center, and then there's a lot of fluid around the tendon, and we named that the bullseye sign because it looks like a bullseye. But really, you don't need ultrasound to diagnose this. If they've got canal sign, fusiform swelling, semi-flexed position, tenderness along the flexor sheath, and pain with passive extension using that flick test that I showed you about, the guy has flexor tendinosus. Now, how are you going to treat this? All right. Well, it depends on the severity. So if you have a mild case, the patient needs to be on IV antibiotics. This is a big deal. This is not something that should be managed as an outpatient. The patient needs to be on IV antibiotics. You need to have the hand elevated. You need to watch the patient carefully. And if the patient's getting worse, the patient needs to be drained. So now the question is, well, how are we going to drain this? Because if we open up that entire flexor sheath, that's going to create extensive scar tissue. The tendon's not going to be moving, and then you're going to have a patient with a frozen finger. So let's think about that a little bit. So there are basically 3 stages that have been described in the management of flexor tendinosus. If you see a picture like this, if the guy's finger like this guy needs to go to the operating room right away. This is an emergency. Okay, as compared to this finger here, which may turn into an emergency, but if you get right on it and treat it, you may be able to avoid it. However, I recognize that most of your patients are going to present late. You're going to probably be dealing with things like this. So you're going to do all the things we talked about: elevation, position of function, IV antibiotics, hot soaks, etc. But or go straight to the operating room. And this is the basic point. If you've got a guy with a significant suppurative flexor tendinosus, you should think of this as if you're dealing with a compartment syndrome. Okay, and you know that if you don't do a fasciotomy in the compartment syndrome, you may end up losing the extremity. So if you have the fusiform swelling and it's tight, that guy needs to be in the operating room right away. Okay, so how are you going to drain it? Well, let's advance to this one. Hopefully, it's not going to be too bad. And what you're going to do is you're going to make an incision over the middle phalanx. You're going to be careful of the digital nerves, which are running on either side. You're going to expose the flexor sheath. And remember, there are pulleys here. We're going to talk more about the pulley. We spent a lot of time talking about the pulleys 2 weeks ago in our anatomy session, but we're going to talk about them again when we talk about flexor tendon injuries. And you're going to make an incision here, and there's going to be fluid coming out. Now, it may be just regular fluid, or it actually may be frank pus. Okay. So now, what we want to do is make a counter incision in the distal palm and thread a catheter up through with a bunch of holes cut in it through the fibroosseous tunnel, that is zone 2 of the flexor tendons, and bring it out, and then irrigate with normal saline or antibiotics. You can put a little penicillin in there or just some kind of antibiotic to irrigate out. And so hopefully you'll be able to drain it and irrigate all the pus out of the tendon sheath with continuous irrigation, and then and treat with antibiotics, and that will take care of the problem. If not, in other words, this is some very advanced stage, then you're talking about debriding the tendon sheaths and surrounding the necrotic tendon, which might even include the tendon itself, and then you may be in an amputation situation. So what we want to do, hopefully, is get to the patient before we're in this kind of situation. So here's a little nicer picture about closed tendon irrigation. Here they've inserted the catheter through a palmar incision. They've made an incision in the distal palm, proximal to the MCP joint. They've opened up the flexor sheath. So now you got the sublimus and profundus tendons going through there. And in addition to that, they've taken maybe a little infant feeding tube, passed it up through the sheath. Here they've made their other counter incision over the middle phalanx, brought the catheter out. Hopefully they put a couple of extra holes in, and then gently irrigating with saline to get all the pus out of there. And then you have the option of hooking this thing up to an IV pump, and then having a gentle, slow, continuous irrigation for 24 hours. However, caution, somebody has to watch this, because we once had a patient where the IV pump was irrigating and the catheter got dislodged, and the fluid was then going into the soft tissues. And we created a compartment syndrome in the hand by just filling the soft tissues up with fluid. In other words, instead of the fluid irrigating and coming out through the flexor sheath, somehow the fluid got into the tissues, and that patient lost a finger. So, so maybe another way to do it would be to have the nurse come by once every 2 or 3 hours and just gently irrigate 5 cc's or 10 cc's through there, just to make sure that pus is not reaccumulating in the flexor sheath. Okay. Now here's actually, I found a video of them doing, and I apologize, this is not a great video, but it'll show you, you'll get the idea that you can't really see as well as I would like what they're doing here, but you'll get the idea. So let's see what these guys are doing. All right, now you notice that these guys are making a incision on the radial or the ulnar aspect of the finger. My preference is to make an oblique incision. I don't know if you guys can see this, an oblique incision across the middle phalanx, so that when you put your retractors in and open up, you're right over the flexor sheath. You don't have to go dissecting. You'll see these guys are going to be dissecting and creating a flap. My view is that that's unnecessary. You just make an incision straight over what you want to see, which is the midline flexor sheath. You'll be better off. But anyway, let's continue now and watch what they're doing. Okay, there they've got their retractors in. Now they're exposing the flexor sheath. All right, there's the flexor sheath, that little white area there. He's exposing it. Usually you open the sheath with a little knife. So here they're putting the infant feeding tube in the sheath and irrigating. And you can see it's hard to actually see what they're doing, but I just want you to get an idea of it. And that's the end of that. Okay. Let's continue. Next. All right. Any questions about management of suppurative flexor tenosynovitis? Anybody got some personal experience with this that they want to share with the group? All right. Dead silence. You got Mugisha, do you see this in your practice? Any of you guys see are managing suppurative flexor tenosynovitis?
It has been a while. It has been a while. I remember I saw a case, and this was from a diabetic patient.
Okay. So if you're not familiar with this, it can be like a mystery of what to do. But it's a very straightforward thing. Any general surgeon can manage this. I mean, if you got hand specialists or orthopedists or plastic surgeons around that are interested in this, that's great. But if you don't, a general surgeon is going to have to step up to the plate and take care of it. And you can, because otherwise you can end up with a ruined hand if you don't get this drained correctly. Okay, so now,
Sir,
yeah.
I would have a question.
Yeah, go ahead.
So are we going to cut the sheath, or are we just going beneath it with the IV or something?
Okay, so what you're going to do is you're going to make a small incision, like a hole, very small hole on the anterior wall of the sheath, and you're going to make it in two places. You're going to make it over the middle phalanx, sorry, and you're going to go at the base of the hand, at the distal hand, right proximal to the MCP joint, because the flexor sheath goes from the mid palm all the way up to the distal phalanx. So you're going to make a small hole in the flexor sheath over the middle phalanx, and another small hole in the flexor sheath in the palm. So you're going to have two incisions. You're going to then pass your catheter either from proximal to distal, or distal to proximal. It doesn't matter. I put a couple of little extra holes in the infant feeding tube, and then just irrigate it so that you're irrigating all the junk, all the pus out of the flexor sheath, and so it's drained. Any other questions?
None, sir. Thank you.
All right.
Yeah, and what's the recurrence?
Excuse me?
And if it, do you need to repeat like after certain days? Or,
Yeah. Okay. So the answer is it depends. One way to do it is to leave the catheter in for 24 or 36 hours, and either put the patient on a continuous irrigation of only a couple of cc's an hour, just to keep the thing draining, or leave it in and keep the things with a cap on it so it's sterile, and then have somebody come by with a couple of cc's maybe every 4 hours and irrigate it with a syringe. Or the other alternative is, it doesn't look too bad. You can irrigate it out once, and then just take the catheter out, and then leave the wounds open, obviously, and then soak the hand. And so really, that's going to be a surgical decision that you're going to make at the time you're there. If it looks like it's a really significant problem, my approach would be to leave the catheter in there as a drain, either just as a drain or preferably with more irrigation, and then but usually within 24 to 36 hours the catheter is out, and then you're soaking the hand, and then what you want to do is what you don't want to end up with is a stiff hand. So the guys, a good thing is to get one of those plastic bowls that you use to wash the dishes with, and then put some warm water in there with some soapy water, get a sponge, and have the patient just sit there and with the hand in warm soapy water, squeezing the sponge so that it keeps moving the hand. Because what you want, though, what you want to happen is you want those tendons to keep gliding through the flexor sheath, and you don't want to get them stuck with adhesions. Any other questions about that? All right. So now we are on to the subject of the anatomic spaces of the hand, and we have to thank our friend Knebel for this too, because he was the guy who described these spaces in the hand where pus tends to accumulate. And of course, this was a very, very big deal in the pre-antibiotic era, because if you had a hand infection, what you were hoping for was that the immune system of the body would localize the infection into an abscess, which then could be drained. And Knebel described these spaces where abscesses tend to occur in the hand. In my practice, I didn't really use this information that often, because most of my patients showed up, not all of them, but most of them showed up relatively early, and I was able to manage the infection with antibiotics and elevation, with or without some drainage. But I didn't really, I usually was not managing big abscesses in these spaces. However, I imagine that many of your patients will show up late. And so I think it's a good idea to be aware of these spaces. So one commonplace is the mid-palmar space that was described by Knebel. And you can see that here are all our flexor tendons. And here's the beginning of the flexor sheath here, mid-palm. And right posterior to the flexor tendons in the palm is this space where pus tends to occur. So this is one place where you might have to, where you might need to be draining. The other thing is, remember we talked about the thenar wad here, where you have the three muscles which abduct and oppose the thumb. And so there is a thenar space here between the muscles where pus tends to accumulate. There is also a hypothenar space here. And then you can have on the back of the hand, there are two places where the pus can accumulate. There is the subcutaneous space, because if you pick up the skin, it's very loose on the dorsum of the hand, and pus tends to accumulate over there. And then you have an aponeurosis over the interosseous muscles, and sometimes you can get pus accumulating under there. So these are all the areas in the hand where abscesses can occur. Then you can, of course, get deep infections where in the interosseous muscles between the metacarpals, in the thumb index finger web space, where you've got the first dorsal interosseous muscle, and then of course the infection sometimes can track all the way up in the forearm. I remember one poor girl. It was a horrible situation. She was bitten by a dog, and she got infection tracking up into from the volar forearm all the way up, tracking up along the tendons into the forearm, and we had to keep taking her back to the operating room and just chasing this infection as it went up the arm, and she ended up with with a big scar on her arm, but fortunately we were able to save her extremity. But it was not fun. So very, very, very occasionally you can get these infections tracking up these bursa. And so this shows you the type of incisions that may be necessary to drain. So we talked about the mid-palmar space. So you're going to need a transverse or an oblique incision over the mid-palm. You can have an incision over the ulnar bursa, an incision over the radial bursa. Remember, if you're making an incision over the radial bursa, you got to be careful that you don't injure the recurrent median nerve, which provides motor innervation to the thenar eminence muscles. Otherwise, the patient will be unable to abduct the thumb and oppose the thumb. You've got these radial and ulnar bursa, which was the problem with the young lady that I talked about, where we had an infection just tracking up through this bursa, through these bursa. So now we are come to the subject of necrotizing soft tissue infections of the upper extremity. And this is a terrible problem. And in my practice, it primarily involved injection drug users. People who were injecting themselves with heroin, and sometimes the heroin would be cut with black tar. They would have all these, they put all these horrible chemicals in with the heroin so that they could sell more heroin, to dilute it, and it would cause it. Now this is old. This is from a paper that I wrote a zillion years ago, but I think it's still useful information. And if we looked at all our necrotizing infections, and we could see that over half of them were. Can you guys hear me, Mugisha? Hello, can you guys hear me?
Yes, sir. I can hear you.
Okay, good, because it said my internet connection was unstable. Right. So you had necrotizing infections all over the place, but actually 56% of the necrotizing infections were in the upper extremity. And you can see that most of them were due to injection drug use, but we had blunt trauma, penetrating trauma, gunshot wounds, pressure wounds. A patient would be unconscious from a drug overdose or a head injury or something, and would be lying on one side for 12 hours before they were discovered, and there would be a pressure necrosis that caused necrotizing infections. So, and then sometimes you can even get it after surgery. So, and most of the time, the patients had an established infection. And I think what happens is you have an established infection that's not treated, and all of a sudden the thing takes off like a forest fire and spreads very rapidly. Now, there are the classic findings of necrotizing infections, which are skin bullae, skin necrosis, crepitus, purulent drainage, and ulcerations are, of course, not limited to necrotizing infections. But, and then so you have those classic findings, and then they are associated, these infections are associated with certain diseases. Diabetes mellitus because of immune incompetence, parenteral drug use, alcoholism. And then sometimes the patients present with organ failure, so that they present in shock. In other words, if you have a patient present with necrotizing infection and septic shock, you can see that patient has a good chance of dying. If the patient is obtunded or unconscious with a necrotizing infection, has a good chance of dying. Renal failure, good chance of dying. Liver failure, good chance of dying. Now, what I didn't show you is, although the classic findings are skin bullae and skin necrosis and all the stuff that we talked about, most of the patients did not have the classic findings. So you have to have a very high index of suspicion that you might be dealing with a necrotizing soft tissue infection. And let's go back to one of the first slides that we showed in this lecture, that you are never, ever, ever wrong to make an incision in a soft tissue infection. And if you do decide to make an incision in a soft tissue infection, go down to the fascia, look at the fascia, open the fascia and inspect the underlying muscle. The underlying muscle must be nice and red. The fascia must be normal. If the fascia is gray, then you got a problem. The bacteriology is usually a mixed aerobic and anaerobic infection. So you've got to treat with antibiotics that'll kill aerobes and anaerobes. Penicillin, gentamicin, clindamycin is one regimen, but you're going to use whatever antibiotics you have, and you're going to be familiar with the antibiotic flora in your own hospital or situation, and make the appropriate choices. But you need broad spectrum antibiotics. But the other point is, if you have a necrotizing soft tissue infection, antibiotics is not going to solve the problem. You have to excise the infection from the body, and you have to get ahead of it. Because remember, this infection is racing like a forest fire ahead. So you incise the fascia, as I mentioned, open the fascia, inspect the underlying muscle, and you can use the finger test. If you can put your finger underneath that fascia and push it all away, you've got a necrotizing soft tissue infection. It all needs to be debrided. All that stuff is dead. And the other thing is, if you're dealing with a drug user, I always put on a pair of cotton gloves. Why? Because sometimes they have broken off needles that are there, and you don't want to stick yourself with the needle. So I always had 2 pairs of gloves on, and if I was dealing with a case like this, I'd get a pair of sterilized cotton garden gloves or something like that to protect my hands in case there's a broken off needle there, because you never know. Now, this is a patient from, oh my God, this is over 40 years ago. This is a lovely elderly lady, and she's, I think, in her mid-70s. In other words, she was about the same age I am right now. And she was living on the streets, and she was going through garbage, collecting stuff that she could bring in, cans or whatever, to recycle and bring in, get some money. Terrible situation. So she cut herself and didn't take care of it. And she comes in, and this is what she looked like. I saw her in the emergency room. And so it didn't look, actually, this is the next day. It didn't look too bad. So I elevated her arm, treated her, put her in the position to function, put her on IV antibiotics, had her in the hospital. And the next day I was shocked because I had her on all these antibiotics, and despite the antibiotics, the erythema, which was over here, had now extended above her elbow. So I was a fellow at the time. So I called my boss up. This was not in the inner city hospital where I usually work. This was in a private hospital where they weren't used to dealing with this kind of stuff. I called my boss up and I said, this is a big deal. We need to go to the operating room. So, okay, we went to the operating room. And we made this big incision to drain it. And here we are the next day. Now you can see you've got dead skin. She's on all the antibiotics known to man now. You can see we made a big incision, but it still didn't solve the problem. And now we got skin necrosis, one of the signs of necrotizing fascia infection. Of course, we already knew it was a necrotizing fascia infection from before. And basically, over the course of 3 days, this infection spread like wildfire to her chest. Now, this is a lady in her mid-70s. And what I had to do was disarticulate her shoulder, cut off half of her breast, and we had this gigantic wound, and here we closed it with skin grafts. And here she is in the clinic, and I asked her, of course this raises also ethical questions. Are we doing the right thing? Doing a major limb amputation in an elderly lady, and she said, "Oh, yeah, absolutely, it was worth being alive." And but the major point of this slide is to show you what 50 years of surgical practice will do to you, because this is actually what I used to look like 50 years ago. So you can take that for what it's worth. So what are my parting words in terms of in terms of dealing with upper extremity infections. First of all, you're never wrong to make an incision cellulitis. And if you decide to make an incision, you haven't done your job. And yes, you've looked at the underlying fascia and you've opened the fascia and looked at the underlying muscle. That's point number one. Point number two, aggressive early repeated debridement every 12 to 24 hours, combined by aggressive resuscitation by professionals in the ICU. In other words, people who know how to take care of sick patients is the key to success if you're dealing with a necrotizing infection. And the bottom line is, if you've got a necrotizing infection, antibiotics alone are not going to do it. You must excise the infection from the patient, as you saw in that last case that I showed you. So in summary, there's a spectrum of hand infections that goes from cellulitis to various kinds of abscesses, paronychia, felons, suppurative flexitinosynovitis, deep space infections in the hand, all the way to necrotizing soft tissue infections. The basic principles of treatment are elevation, antibiotics, and dressing the patient with the hand in a position of safety. Mainly, the wrist is extended, the MCP joints are flexed, the IP joints are straight, and the thumb is opposed, that it is abducted out of the plane of the hand, so it can squeeze a beer can, so to speak, as my joke goes. And that, ladies and gentlemen, completes my remarks on hand infections. We have about a little more than 20 minutes left. Mugisha, we can. I think what would be best would be to have a discussion if people have things to say. Otherwise, we can start on tendon injuries. What, you're the boss. What would you like to do?
Maybe we discuss, because it's quite interesting. So yes, welcome all of you for a discussion. It is very interesting, hand infection. Maybe I start with an experience. I attended a patient 3 years ago, and he was having hand infections on the palm aspect, so swollen, and it was spontaneous. That was my first case. Yeah, no injury, no what.
Try to speak a little louder, Mugisha, because at least I'm having trouble hearing you, and I suspect everybody else is too.
Oh, thank you very much. I'm saying I had a patient who was diabetic and had a kidney failure, had a transplant done. He was in immunosuppressive medications, and he developed a hand infection that was so serious on the palm aspect of the hand. And we did serial debridement, and when we finished the right, start getting healing, he went into the other hand, and it was spontaneous. It was quite interesting, but we managed with antibiotics and serial debridement for a couple of days. Any similar experience at your end?
Well, I think that's a very good point that you just made. That you've got to when you've got a bad hand infection, particularly in an immunosuppressed patient or a diabetic patient, you've got to be like a bulldog and just don't let go. Keep chewing on it and keep going back and debriding it till you get ahead of the infection. And because if you're in a situation like that, you debride it once, you put the patient on antibiotics, you see the guy once every day or every other day, you know, that's not going to do it. This is hard labor. If you're gonna save the patient's hand or sometimes even save their life, this is hard work. You got to keep going back. And as I mentioned, every 12 to 24 hours sometimes is necessary until you really got a clean wound and the thing is stable. Anybody else have any experiences that they want to share?
Yeah, there's one from chat. Go ahead.
Yeah, two things. Number one, As per my experience with hand infections, I always have experienced that if you don't engage the rehab as you initiate your treatment, the outcome is very bad. That you may get the infection healing, but the function is compromised because probably the healing takes place with a lot of fibrosis. They will end up having either flexion or extension not possible for the fingers. So I think rehab, as you start the definitive treatment, is very, very important. That's number one. Number two, I wanted to know whether, Prof, there is a chance that we may get subacute tenosynovitis of the flexor tendons. I came across a patient who was attacked by a lion and developed the problem of failure of flexing his fingers, and it appears like the carnival signs were positive. So I suspected probably had the tenosynovitis, but now most likely I was thinking it was a subacute or it was a non-bacterial probably, because the symptoms were a bit feeble. And if it was a really virulent bacteria, the symptom would have been more severe and probably would have called for attention as early as possible. But this one came 3 months later.
Okay, well, thank you very much for your comment. First of all, regarding your first comment, I think that was a brilliant comment. And but not everybody has access to physical therapy, depending on what kind of hospital you're working in. And but you're 100% right that that the post-operative or even in the hospital while the thing is while you're still managing it, yet putting all those joints through a range of motion is critical. So if you've got physical therapists that can come and do that, fantastic. You get them involved from the beginning. If you don't, then it's our responsibility to do that. And as I mentioned, one good therapy, which is easy to do, is if you get one of those plastic basins that that's used to wash the dishes, put warm water in it, put some soap suds in it, get a sponge in, and if the patient can just sit there and with the hand in warm soapy water and keep flexing, keep squeezing the sponge, and that moves all their fingers through a range of motion. And then and then remember to when they're while the wound is healing, to keep the wrist in the position of the safety. That is the wrist extended, MCP joints flexed, the thumb abducted or opposed, like that. Okay, so now number two. You got a lot more experience with lion attacks than I have, because my experience with lion attacks is zero. However, I have taken care of one guy that was attacked by a leopard to his chest, but not by a lion. But at any rate, but subacute tenosynovitis, I have some comments about that. Sometimes you'll have a patient who has canaval signs, and you'll make the incision, and there's not pus there, but there's a little rust-colored fluid that comes out. And so this is either an early infection, which is not suppurated yet, or sometimes there could be even a viral infection in the flexor sheath. I'm not sure, but I have encountered patients with low grade suppurative flexor tenosynovitis, where there's just a little fluid in there, and that's relatively easy to manage in the sense that you make your counter incisions, you wash it out, and then they usually heal up and get better. Whether this thing had anything at all to do with the lion attack is another question. I mean, did the lion bite the hand? That's the question. So whether it was related to the lion attack or whether it was just something else, I don't know. You didn't give us that information about what kind of wound they had to the hand. But yes, there are subacute suppurative flexor tenosynovitis, and the treatment is basically the same, but I think you can expect a better outcome. Anybody else have any comments?
Yes, this is Dr. Sam from Mulago.
Hi.
Sharing my experience with the uninjured. The challenge is always seen is with the dressing the wound and splintage. In most cases, after the surgeon has done the incision, the dressing is left to the nurses, and sometimes you're disappointed when you go to the ward and you find the whole fingers are closed, wrapped together in a crepe bandage, and then you find the fingers, the infection can spread from one finger to the other. So the emphasis usually is separating the fingers when you're doing the dressing, not closing up the whole fingers together. And then the splintage also sometimes a challenge, because sometimes like in Africa setting in Uganda, mostly we're using the plaster of Paris backslab to do the splintage, and it's a bit of challenge with the nurses. So I don't know, in your experience, your advice, what is the best splint to use in keeping the position in the hand when you do it after the dressing?
Well, thank you very much for that comment. I actually have a lot of experience with dressings filled with pus not being changed, all sorts of problems, and that's, you know, basically. And we had courses previously on pre and post-operative care, and one of the points I mentioned was that if we don't care, the nurses are not going to care. So we have to make rounds twice a day and look at the dressings and encourage the nurses. And if they see that we're interested, they'll be interested. If we're not interested, they won't be. And I think when you're making rounds and point out these problems, you're sending an important message to the nursing sisters who are overworked. But in terms of putting the dressing on, I also use plaster Paris, and I just use splints, but they have to be very well padded. And usually what I would use is a volar splint. After putting the dressings on, I agree with you 100% about putting gauze or some other type of dressing, separating each of the fingers, putting the volar splint on well padded. Sometimes what you can do is just take cotton wool roll and place it on there before you put the plaster on, so that the wrist is extended, and then sometimes you can even put some cotton wool roll over the top of the fingers and take another plaster sheet and just put it over the top to flex the MCP joints. It depends on the situation that you're dealing with. But the bottom line is, when you finish, you want to have a nice plaster dressing with the wrist extended, the MCP joints flexed, and then sometimes you can actually arrange the dressing so you can get access to the wound without taking the splint off. You know what I mean? So that if you've got a wound, you can design your dressing so you can get in and out and look at the wound and irrigate it or expect whatever you're going to do, but without taking the whole dressing down. And every wound is going to be a little bit different. You have to use your creativity. Anybody else have any comments?
Yes, Professor. Thank you. This is Lemfuka from Liberia. Thank you for your presentation. I met you in the middle of the presentation, but I have maybe one or two comments and one question. So I'll start with my comment, then I'll finish with the question. For my comment is about the necrotizing soft tissue infection of the hands. As you said, these patients are really serious, and if you don't pay attention, you may find yourself in serious trouble and even lose your patient. So most of the hospitals that I know here in Sub-Saharan Africa, we don't have ICU, and those patients will be sent after the debridement on the ward. I think to own the wound should be the key. So you should take these patients, this wound to be yours. So as the professor said, 12 to 24 hours debridement. So from my experience, those patients are diabetics and medical people are following them. So sometimes if you do not pay attention, they come late in the OR, and then maybe the nurse are not aware about the seriousness of the case. They just do the dressing and then send the patient back. And then by the time you saw the wound is really extensive and has gone far. So owning the patient and the wounds are key to the success, and also depend on your determination and aggressiveness that you have, because antibiotics alone, as Professor said, will not help you. But if you are seeing this wound every day, trying to do serial debridement every day, and you're on top of this, you may get the key to the success of saving the limb and the patients. That was my first comment. So my second one is about physical therapy. We usually don't have physical therapy, as Professor mentioned, in most of the hospitals. So another experience I have, each time as a surgeon, you are there when the dressing is done, you manipulate the patient when it's under anesthesia. You debride, you manipulate the patient's the hands, and you put him back on the splints on the neutral position. So daily manipulation will help you to keep the function. By the time the wound is granulating and is out of the infection, you also have success with the function on the limb. And nutrition also is the key, because most of them are diabetes. So you should pay attention that the patient is well feeds so that the healing can be success. That was my small comment. And my question, I didn't hear, I don't know, I met you in the middle about hand injury. We also have a lot of cases with gunshot on the hands. So how do we approach them in terms of debridement versus amputation? Like somebody get one gunshot on the hands and got damaged the middle and the ring finger, but we are not sure if the finger is still viable or not. Do you right away amputate them or give a chance? You debride what you can debride, do the dressing, you pin, and then watch over on the finger if it is survive or not. Then you decide for the next step. What is your approach? Or what do you do?
Well, thank you very much for your comments and your question. I'll deal with the question first, and then support some of your comments. Regarding complex injuries to the upper extremity in the hand, whether from gunshot wounds or blunt trauma or machete injuries or whatever, we're going to be talking about that later on because we have an entire lecture on the mangled extremity, the approach to the mangled extremity. So we're going to spend a good hour on that. However, to just answer your question, in the initial approach is to do conservative debridement and to go back to the operating room, within 12 to 24 hours to see what is alive and what's dead. Because as you rightly said, a lot of times you look at this horrible situation and you say, oh my God, we just have to cut the hand off or whatever you're going to do. But, and that might be the case, but if you go to the operating room, clean the hand up and just dress it, elevate it, and then go back for a second look 12 to 24 hours later, it will be obvious then what's alive and what's dead. Because what you want to do is debride the minimum amount of tissue, and then even if you have to cut the finger off, you might be able to save some of the soft tissue and use that as local flap coverage to reconstruct whatever you're going to be doing. And we're going to be, as I said, we're going to spend an entire hour on this subject. But to answer your question very briefly, my approach is to do very conservative debridement if possible, and then make a definitive decision 12 to 24 hours later. So that's, I hope I answered your question.
Yes.
But I just want to support your comment that, look, even in a high-income country like the United States, somebody's got to take ownership of the patient, and nothing's going to happen unless you make it happen. And we are, as surgeons, I like to consider ourselves as peaceful warriors. We are doing battle against disease, against injury, for the good of our patients. So I always used to tell my residents, I said, if you're interested in an easy life, go into administration or go into high tech or something like that. If you're going to be a surgeon, this is manual labor. This is hard labor. You're up in the middle of the night this is our life, and we have to assume personal responsibility and accountability for outcome, which means we have to be there, and we have to be there every day or multiple times during the day, depending on how sick the patient is. And so I thought your comment was right on, and I just wanted to support that. And the other thing with this whole thing about not having intensive care, that's a huge problem. We just gave a course a couple of months ago on intensive care. I've given intensive care courses on multiple occasions in the various hospitals in Tanzania, and I think the intensive care in the places where we were working improved. And so I think that if you're going to do big surgery, you got to be able to take care of the patients post-operatively. And if you don't have intensive care where you are working, if you can get a cadre of people together, nurses, if you have, I don't know whether you have ventilators or not. If you have ventilators, whoever is taking care of the ventilators, and sort of meet once a week and make a plan about what you can do to improve the situation. And there's probably, I remember when I first went to a certain hospital in Africa, they were taking patients with septic abdomens after big surgery, and everybody was disappearing, and the patient was breathing spontaneously through room air, going to wherever they were going, and it wasn't surprising that 4 hours later they were dead. But if you have a problem like that, I would encourage you to get a small working group together of nurses, doctors, maybe administrators, and say, okay, we have this problem. What can we do to make things better? And you might not be able to make it perfect, but my guess is you can make it a lot better. So that would be my comment about that. Any other comments? Dieudonné, do you want to?
Yes, there is a comment when you want to do local anesthesia. The gentleman is asking the role of epinephrine or adrenaline with
Okay.
epinephrine.
So I personally do not use epinephrine or norepinephrine with local anesthetics in the finger. And the reason is the two digital arteries are end organs, and if they go into spasm, there's a chance that you could lose the finger. Now, if you do it, a lot of times you're not going to lose the finger. But personally, I don't want to take that chance. Proximal to the wrist. So if you're doing an ulnar wrist block or a radial wrist block, and remember we talked, I think we demonstrated that a couple of weeks ago when we were talking about acute hand injuries, how you manage them. Or if you're doing an axillary block or a supraclavicular block, some kind of regional anesthetic, it's fine to use epinephrine there because you're dealing with big vessels. You're not going to create an ischemic situation. On the other hand, my personal preference is not to use it in the finger. If you want to use it, that's a decision that you'll make. Usually, if you're working on the finger for draining an abscess, you don't need long-lasting anesthesia. You can use a regular digital block without epinephrine. You make your incision and drain it, and then you're done. On the other hand, if you're doing a flexor tendon injury, you're not going to be doing that under a digital block. You're going to be doing that with a general anesthetic or some type of either a beer block, an IV regional anesthesia, or a axillary block or some other type of regional anesthetic. So I don't think it's a big issue, because when you're doing a digital block, most of the time you can do whatever you have to do within 20 or 30 minutes, and then and you don't really need epinephrine to prolong the block. That's my personal opinion. You may have a different opinion, and if you do, I'd like to hear it. And because you don't have to agree with everything that I say.
Yeah, thank you. In the interest of time, we are on time exactly, and would like to call upon to the next meeting, which will be next Thursday, unless there is any other burning issue
Okay, so
from all
so
of
next
us.
week, we're going to talk about either extensor or flexor tendon injury. We're going to start getting into tendon injury repair.
All
I
right.
wanna- I want to thank everybody for all your comments. This was a very stimulating discussion. I really enjoyed it, and I hope you got something out of it.
Yeah, it's true. We also want to extend our sincere appreciation for your time and commitment toward improving our understanding and reminding us, making some revisions on what is known in the hand surgery. Thank you very much. Until next week on Thursday, same time, same day.
Okay,
Same
bye-bye,
team.
everybody. Thank you.
Bye, bye,
Bye,
bye.
bye.
Thank you, sir. Goodbye.
Thank you. Bye, everybody. Thank you.
Bye.
Thank you, Mugisa.